to this ALiEM and Annals of Emergency Medicine hosted discussion. Today we're talking about opiate prescription drugs. As many of you know, this is the main cause of fatal prescription drug overdoses, and of course deaths are just the tip of the iceberg of misuse and addiction. So on a day-to-day basis, doing the right thing for our patients with pain complaints has become a daily challenge for emergency medicine physicians. We're all here today to discuss a recent outstanding piece in Annals of Emergency Medicine entitled The Opioid Prescription Epidemic and the Role of Emergency Medicine. This was written by Sabrina Poon and Margaret Greenwood Erickson, two residents in the Harvard-affiliated Emergency Medicine Residency Program. So Drs. Poon and Greenwood Erickson, thanks for joining us today.
Thanks so much for hosting this discussion. You know, one of our main objectives in writing the paper was to foster dialogue like this, so we're thrilled. You know, this paper and our interest in the area definitely stemmed from our own experiences as interns working in the ED. And I think there are really two main challenging decision points. One, do I think this patient would benefit from opioid medication more than it would harm them? And two, what should I prescribe them? And not only what, but how much, for how long, what kind, and also what else might help them, whether it be different classes of medication, outpatient referrals, and the like. So I'll talk a little bit more about this first point and let Margaret talk more about the second. So regarding the decision of whether an opioid medication would benefit a patient more than it would harm them, I think in some cases the decision is usually quite straightforward. For instance, patients who come in with acute, severe, time-limited pain complaints, and I think fractures are sort of the classic example. But in most other cases, it's not, and certainly I think most of the time patients who present with pain are in pain. So as we mentioned in the paper, providers aren't necessarily very good at detecting opioid-seeking behavior or patients with addictions. And of course, your patient could be, and I think I see this a lot, both be in pain and be developing or have an addiction. And it's hard to ignore the increasing number of visits we get from opioid overdoses. So just to give you a brief resident's perspective, since I guess that's what we're here to do, as interns, we're the sole resident providers in the fast-track area of our emergency department overnight. And during those few hours, we do typically see a number of patients with acute on chronic exacerbations of back pain. And I quickly felt somewhat helpless in treating these patients, in part because it was confusing that after a string of overnight shifts with different attendings, your practice pattern changes daily for patients with similar complaints. And I think this is true with other chief complaints, certainly, but typically that's within a realm of evidence-based medicine. And, you know, it's also hard to know the patient's history if they aren't well known to your system with notes from prior visits either to the ED or to their PCP. So I think in these instances it could be helpful to know what kind of prescriptions these patients have recently gotten, since they either might not know or might not be so forthright with you. And I think this is where the PDMP could be helpful. But it's just one data point that could be used along with other considerations like their presentation, their age, what kind of follow-up they have, and so on and so forth. And unfortunately, as one commenter pointed out on Twitter, I think, at least in Massachusetts, and I think this is true in other states as well, residents don't actually have access to the PDMP. And so I think, as that commenter pointed out, the odds of using it if we don't get in the habit now kind of are slim. And, you know, I think now that we're very seasoned PGY3s, I think our practice pattern may have changed a bit, but certainly those initial experiences, and I think especially frustrations, are pretty universal no matter what your level of practice. So with that, I'll turn it over to Margaret.
Yes, thank you, Sabrina, and good morning. I think another issue we face in appropriate opioid prescribing in residency is a lack of formal education. As Sabrina discussed, sometimes it's challenging to determine when to prescribe opioids, and in part because of the reasons she mentioned, but also in part because of a lack of structured education on opioid prescribing. Compared to education on other classes of medication, there's little curriculum dedicated to opioid analgesic prescribing in emergency medicine residencies and actually in medical school as well. I have a memory as an intern in my first month of residency. I was in the fast track section that Sabrina mentioned, and I saw a young woman who was demanding Vicodin for her chronic back pain. It was 3 a.m. She was causing a scene, and the attending told me, you know, he was very busy. He said, you can kind of do what you want. You can prescribe her some Vicodin, or you don't have to. Either thing is fine with me. And I remember thinking, gosh, how can there be so much gray area? In my inexperience, it had never occurred to me that a prescription for a medication, particularly something like a pain medication, maybe could be left to what sort of felt like the toss of a coin. I'm embarrassed to recall I really wanted to just prescribe her the Vicodin to get her to leave. She was screaming. The nurses were getting frustrated with me, with her. And in my inexperience, I really didn't know how to sit down with her and have a conversation with her about my concerns about, abuse or drug diversion and her risks. I sat down to write the prescription, and I realized I didn't even know what opioid was in Vicodin. I wasn't quite sure what the normal dose was, and I didn't know how many pills would be considered normal. Other new interns may experience a similar situation to this as I did in my first week of residency. And I think it speaks a little bit to the lack of knowledge on opioid pharmacology and opioid prescribing principles, and a lack of education on how to discuss concern for addiction and overdose with patients. This education is very important for emergency medicine residents. Pain is one of the most common chief complaints in the emergency department, and opioids are one of the most commonly prescribed medications by emergency providers. Other specialties like family medicine and internal medicine have started implementing resident education programs on opioid prescribing, and I think our field has been a little delayed to do the same. In our paper, we do propose a curriculum we think could be effective if implemented, and we're working with our own residency program to see if we can integrate it. Finally, in addition to formal education, emergency medicine residents often look to clinical guidelines for guidance on management of specific diseases. Unfortunately, due to the subjectivity of pain, we'll likely never have a clear-cut clinical guideline or strict standard of care for appropriate opioid prescribing. However, ACEP chapters and state-based groups of emergency providers have been working with public health departments over the last several years to develop voluntary opioid prescribing guidelines. The ones probably most well publicized here on the East Coast were the guidelines crafted from a well-known group of emergency providers in New York and the New York City Department of Health and Mental Hygiene. Many states now have these guidelines, and they're variations on the same theme: avoidance of prescribing long-acting opioids, limiting prescriptions to a 3-day supply, and recommending against replacing lost, stolen, or destroyed prescriptions. In summary, we propose that both improved resident education and establishment of prescribing guidelines may assist in more appropriate prescribing of opioids in the emergency department.
Thanks, Margaret. I think you guys did a really great job of framing the problem on the ground. A very heterogeneous group of patients. One of our biggest causes for presentation in the emergency department are these pain patients, or often sort of undifferentiated pain patients. We really lack uniform approaches, and from a trainee's perspective, really being exposed to an apprenticeship with a lot of masters who practice very differently in terms of how willing they are to prescribe opioids. I will say, too, the issue of administering opioids during an ED visit is also a problem, but in this talk we're going to focus on really the prescriptions that we administer. So I want to switch gears and go to Dr. David Gerlink. He is a medical toxicologist and an internist and head of the Division of Clinical Pharmacology and Toxicology at Sunnybrook Health Sciences Center in Toronto. Dr. Gerlink has published extensively on issues related to opioid misuse, including a JAMA piece on the New York opioid prescribing guidelines. So welcome, Dr. Gerlink. Morning. We're hoping that you could speak really broadly just for the entire field of medicine and just address what the most effective means of addressing this problem are. Dr. Greenwood-Erickson alluded to some of the solutions that are emerging, including PMPs and increased provider education, and I just hope that you might talk about the role of those in stemming this problem.
So thanks. I think the first point to make is that if this was an easy thing to fix, we would have already fixed it. And one of the reasons it's not so easy to fix is because it's a really complex topic. I think the first thing that we have to acknowledge is that we really do have an epidemic, and I say that, and I think everyone watching this probably agrees with that assertion. But I've seen some, smart and well-meaning people ask or suggest that this isn't an epidemic at all, or to counter with the argument that there's an epidemic of pain and we should be focusing on that. So I think the first point is to realize this is an epidemic, and it's one largely of our own making, in part because, as has already been said, pain is such a common thing, and as physicians, we're conditioned to want to make people feel better, and we have this perception that opioids are our best tools for doing that. And sadly, I don't think that's actually true. So, in terms of addressing this on a global scale, actually, Irfan Dalla and I wrote a paper with Nav Prasad in the BMJ a few years ago, and it was entitled "Facing Up to the Prescription Opioid Crisis." And we talked a bit about the genesis of the problem, but we spent much of the commentary talking about ways in which this can be addressed. I don't think any of these measures on their own are going to be effective. I think it's sort of it's the use of them together, and physician education is really important. I don't think it's as effective as we'd like to think. I think we probably might call it physician de-education, because a lot of why we do what we presently do and the problems that we've seen are because we've been educated wrongly about the role of opioids in the management of pain. And that can be traced back in many instances to the drug companies that make these drugs. So I think physicians need to gain an appreciation for the fact that these aren't as effective for chronic pain in particular as we think. The evidence for their use is really quite weak. I mean, I think many physicians would be surprised to know that there's not a single randomized trial of more than 16 weeks duration of opioids for chronic pain, and most of these trials compare opioids to placebo, which is something we'd never use to treat pain. So, and yet, we prescribe these drugs at high doses for years and years. That's a practice that would never be acceptable to physicians in cardiology or in oncology. So I think educating doctors about the risks of opioids, how bad the data are, the potential for interactions with other drugs is important. PDMPs, and there's a nice discussion about this in Sabrina and Margaret's paper, a nice free article online in Journal of Med Talks a few years ago by Jean Marie Perron and Lewis Nelson. I think these are a really important part of the solution. They're not going to be a solution on their own, but if you have access to information, I think it can really have an important impact on physicians prescribing in Emerge or in general practice. Policy changes, moving Vicodin, for example, to Schedule 2 is a no-brainer, despite the fact that it was resisted by a good number of people. And I think more research. The idea that we put patients on these drugs for months and years, despite no evidence that that's an intervention that offers benefits that outweighs the risks, is really hard to fathom, and it's because there's no obligation on companies to do these kinds of studies, and I think they should be mandated too.
Okay, thank you. Dr. Amrashahi, can you talk about, I'm sorry, I didn't introduce you. Our next panelist is Dr. Marianne Amrashahi, who is a medical toxicologist and an emergency medicine physician in Washington, D.C., and also the first author of two much talked about papers on emergency medicine prescribing, opioid prescribing practices, both for children and for adults. I was hoping that you could talk about really the ED's role in the prescription opioid crisis, and both in initiating it and also in hopefully contributing to reducing the problem.
Thank you very much, everyone, for joining us. So really, there's many different ways that we can approach this problem. So number one, in the emergency department, many people think, is that one prescription that I'm giving someone going to contribute to their subsequent non-medical use, misuse, or addiction? And there's really a great piece that I'd like to encourage everyone to take a look at. It was actually in the Journal of Medical Toxicology in 2012, and it was a great piece written by an anonymous nurse who actually chronicled how one opioid prescription actually led to his subsequent abuse and addiction. And I think, although there isn't a lot of randomized controlled data to say how one prescription actually can lead to opioid misuse or abuse, I think this is a really great perspective, because I think a lot of emergency physicians out there think, well, how much is this one prescription that I'm giving this patient today going to contribute to their non-medical use? And I think it's a really great perspective piece. A few other points about the emergency department and how we're initiating and perhaps contributing to the problem. I know we focused a lot on discharge prescriptions, and I think that's very important because the discharge prescriptions are going to be the things that get subsequently diverted or sold and can be more easily funneled into non-medical use. However, at the same time, when we did our study, we found that there was a really substantial increase in opioid analgesics administered in the emergency department. And the reason that I'm kind of mentioning this is I think that it does have relevance in that many years ago they did studies in burn patients. And it was about 30 years ago where they said, well, the acute administration of intravenous opioids didn't lead to subsequent abuse or addiction. And that's the data that's typically cited now in justifying their use. However, this really isn't a patient population that's completely extrapolatable to the emergency department. And now we have much higher rates of baseline opioid use and also misuse and abuse. So how the acute administration of IV opioids in the emergency department really contributes to the introduction of a pattern or reinforces a pattern, I think is actually just as important as the discharge prescriptions that we're giving. In addition, some of the other things that we found was really that there was a lot of increase in the potency of the agents that we were using in the emergency department. So over the 10-year study period that we looked at, we had found that depending upon your complaint, there was a 600 to 800% increase in dilaudid or hydromorphone use compared to a 300% increase in morphine use. And these are agents in most emergency departments that are given parenterally. So now are we having a lower threshold for giving parenteral opioid analgesics, which is something to think about. And then also when you look at the relative potency of the agents that we're giving, we're maybe suggesting that our population that we're treating is much less opioid naive than they were 10 years ago. So just another thing to think about, because the oral medications, for example, the oxycodone, which is just given orally, only increased 100%. So the relative increase is really in these high-potency parenteral agents, and I think that's something to bear in the back of our mind. One other thing that we'd also noted in a separate study that we haven't published yet was that we found that there was a really substantial increase in triage level 4 or 5, so less acute visits. We're also seeing these very astronomical increases, 400 to 500% increases in hydromorphone use for our fast-track patients or our low acuity visits. So once again, suggesting that we're having a lower threshold for giving these medications. And then finally, one other thing I wanted to really focus in on was the indications that we're giving opioids for. So we've published a separate paper, for example, just looking at opioid analgesic use for headaches recently. And once again, the studies that show benefit are really with the serotonergic agents, perhaps the triptans, and really the American Academy of Neurology, the ACEP guidelines don't mention opioids as first-line therapy, for example, and actually discourage their use. But at the same time that we were finding that of all the headache therapies over 10 years, the ones with the largest increases were opioids, which actually isn't guideline congruent. So we also looked at back pain and dental pain and other chronic pain conditions where opioids may not have the best evidence basis. However, their increase in use was astronomical. Finally, we also found that there was a really substantial increase in opioid analgesic groups use amongst all patient groups. So amongst all racial groups, amongst all ages, amongst payer types, hospital types, and also prescribing rates went up amongst all provider types as well, whether we were looking at physicians, whether we were looking at mid-level providers, nurse practitioners, physician assistants. And interestingly enough, and tying in with your article, we actually found that the highest rate of increase was amongst trainee physicians. So tying that all together, I think that we really need to be mindful that the one prescription or the one order that we may write for an opioid analgesic may have impacts for that individual patient down the road. Number two, we want to make sure that we're prescribing for evidence-based indications, and then number 3, keeping in mind all the other interventions that have been discussed previously, including the prescription drug monitoring programs, as well as some of the guidelines that we've enforced.
Thank you so much. All amazing points. Doctors Amershahi and Gerling, on the blog associated with this hangout, somebody raised the issue of patient education. And I wonder where we are as far as, sort of shared decision making with patients, making sure they're informed about the side effects, and whether we do that enough, if there's any sort of emerging data on that, and what the role of that could be in emergency departments and also in just care facilities in general.
I don't know if there are emerging data on that, but I think it's something we don't do as often as we should. We do it with statins and we do it with other drugs too. But I think part of the reason we don't do it is because we don't want to scare patients off. But I think the bigger reason is because we ourselves don't really have an honest appreciation of the benefits and risks of these drugs. I mean, you think about whenever you give a patient a drug or do any kind of intervention, you're always doing it with the hope that the benefits are going to offset the risks. And we have, collectively, I think, and the comments that were just made, I think, speak to this, we have lost a lot of the respect for opioids that we had 15 or 20 years ago because we see them so often. When probably 20% of the patients I admit are on a chronic opioid, it's very easy for residents and for staff just to become inured to the fact that opioids are everywhere. And so I think because we don't have an honest appreciation, or because I think we view in the best possible light opioids sometimes when we're trying to address pain, it might actually be difficult for us to involve patients in the decision-making process.
I think just to kind of add to your point that, when I've attempted to have these discussions with patients, sometimes, especially in the emergency room, they're there for an acute painful condition, and when you try to sit there and discuss opioids with them, they really just want their pain to go away. Then secondarily, when you have somebody who's maybe a long-term chronic user and it's the only thing that's worked, and then you start discussing, well, I'm not going to give this to you or I'm going to take it away, it becomes a much more difficult thing to convince the patient of. So even though you may do your education to the patient, the problem is often is the patient engaged in your education, and I think that's something that we really need to work on by also changing the climate and how we think about opioids as well.
That's a really important point, and the distinction between the naive patients and the patients who are chronically on these drugs. I am convinced that there's a huge swath of the population who take these drugs chronically. They don't abuse them or misuse them. They follow the doctor's directions, but they've developed tolerance to the drugs. They've developed dependence in the course of long-term therapy, and they have the perception that if these drugs aren't given, and it's actually an accurate perception that if the drugs are taken away by voluntarily or by the act of a physician, that they're going to get sick, and they will get sick. They'll experience opioid withdrawal. So just to make the point that there really are there's at least two populations of patients, and the one that you just touched on, I think, is probably the most difficult.
Well, with that being said, I wonder if we can just go down the line and give one walk-away point for physicians, emergency medicine physicians, struggling with this problem in their day-to-day practice. I've heard people say that's kind of the bane of their existence, is deciding what to do with patients with pain complaints who wish to walk away with opioids. So why don't we start? We can start with the residents and go straight through, and then I have a separate question for the medical student. But why don't we start with Sabrina? What is a walk-away tip for people working in the emergency department who have to, go in later on today after they've seen this and decide what they're going to do about their pain patients?
Yeah, actually, Margaret and I were working on the same shift. We overlapped for a few hours yesterday, and we kind of approached each other because I had a patient who fit this description exactly. Who was on having an acute on chronic exacerbation of her pain and was causing a bit of a scene, and it was challenging. And I think in that instance, actually, it would have been really helpful to look her up in the database because we just weren't sure where and what she was getting. I think going forward, and Margaret and I have discussed this before, but I think advocacy to try to make these changes, to make it more accessible, and to hopefully change things and to raise public awareness and everything is one way that you can keep perspective sort of globally as you're going about your day-to-day practice. And I think it's going to be as Dr. Durling mentioned, if it were easy, it would have been fixed already. So it's a long process, and just keeping the bigger picture in mind, I think, as you're in the trenches, so to speak.
Yes, thanks, Sabrina. I think the one take-home I'd like to give people is to think also about having these tough conversations with patients. I think we often shy away from having to speak with them about our concerns about opioid medications. And I think, as Dr. Durling mentioned, we really should be having a conversation with them about risks and benefits. And if we do think they're at risk for potential for abuse or misuse, I think we should really address that. It's difficult to have those conversations, and they're often very confrontational, and so I think we tend to shy from it. But I think that's really critical, and I think it really is important for patient care to make sure we're addressing that as well if we think somebody is at risk for opioid addiction or abuse.
Dr. Durling?
I guess if I had one point to make to physicians, it would be that despite our perception about the role of these drugs, they just don't work very well for patients with chronic pain in particular. And what we really need is better drugs for pain, drugs that work better than opioids and NSAIDs and others, and are relatively free of toxicity. That's likely to be a very long way off. And so until then, I think that we have to lower our expectations about what opioids can do for patients. And I think we actually have to help patients lower their expectations as well. Nobody wants to be in pain, and no physician wants their patients to be in pain. But the attempt by physicians to extinguish pain or to reduce it excessively has just created enormous harm. And I think it's our responsibility to try and undo a bit of that.
Dr. Amar-Shahi?
I think, just keeping with everyone's points, I would really like to say that treating pain is really a multifaceted approach, and I think that it involves multiple providers. So I think us in the emergency department in particular, I think we really do need to try to optimize non-opioid therapies and make sure the patient has an alternative. And then secondarily, I know this is very hard to do during a busy shift, but at the same time, if you have patients that you're concerned about, to reach out to their primary care providers if they have one, to try to coordinate care and follow up, because I think those things are going to be really important as well, as opposed to us just not writing opioids, but really to give them an alternative and a safety net.
Thank you all. I just want to, two more things. Scott Kovner, you've been listening in as a medical student entering your clinical practice, and I'm just wondering what you walk away with this from the learner's perspective, and maybe a word on how this could be incorporated better into a medical student curriculum.
Absolutely, and thank you for having me to talk about some of my thoughts. I think from a medical education perspective, there's certainly a huge lack of education directed towards this topic. It's definitely a hugely underserved area in the preclinical years especially. And I think that this issue might be addressed with sort of a three-pronged approach. One, talking about the threshold knowledge that medical students need to obtain to really understand the problem and understand the practices that they observe when they go on their clinical rotations. The second point being a clinical correlation. So we've talked a lot about today the different patterns of practices. So trying to understand the absence of a strong clinical guideline to how opioids are being prescribed, make sense of the vastly different approaches some of their mentors might take in dealing with the pain of their patients. And I think thirdly, an important point is also an awareness component of their education. So there's certainly a huge, extraordinary set of opportunities for outreach in the community that a lot of hospital systems and medical schools are based in, and greater involvement in harm reduction programs or awareness programs or addiction treatment programs represents a great opportunity for medical students to get more involved and more educated about these issues, as well as involve mentors and faculty members that are really interested in helping to solve this problem. So I think in addition to actually adding more baseline material into curriculums, which is hard to make a strong recommendation for since medical schools have very different curriculums across the country, it's important to, I think, really take the time with medical students to, in clinical practice, to sit down and explain the thought process and reasoning behind the specific pattern of practice you might follow in the absence of clinical guidelines, or if you do follow a clinical guideline, to help explain what specifically is going on in a specific instance of opioid prescription and how that student can help shape their understanding of the issue in light of all the other clinical experiences they might have had.
Thanks, Scott. I hope that we can do a better job with the next generation of physicians in educating them about the use of opioids in their practice. That pretty much concludes our panel. I know Dr. Poon and Dr. Greenwood-Erickson, you wanted a few acknowledgments for your resident piece.
Yes, we just wanted to thank a few of the attending physicians who provided editorial support and mentorship both with this manuscript and with our research interests. And those people are Dr. Scott Weiner, Dr. Jay Scher, and Dr. Margaret Sandy. Thank you so much for having us. We really enjoyed this opportunity.
A really big thank you to all the panelists, and I know this will really contribute to the knowledge and understanding, and I think the mission for emergency physicians out there watching this program. So I appreciate it.